Hello and welcome to the podcast. This is a special edition of the podcast. My name's Ian Lowndes, one of the consultants in the Paediatric Emergency Department in Derby, and I'm pleased to be joined by a good friend of the podcast, Dr Alasdair Munro, who's a Paediatric Registrar and Clinical Research Fellow in Paediatric Infectious Diseases. Good evening, Alasdair. How are you?
Yes, I'm very well, thanks, Ian. How are you?
Yeah, good, thank you. And we're talking today about, well, the only thing that anybody's talking about at the moment, which is, of course, coronavirus. And this podcast, just as a sort of caveat going out, we're recording this tonight, which is Wednesday, the 11th of March, 2020. So details from this podcast will be correct as of today. And we're specifically talking about children and coronavirus. So just to start off then, Alasdair, thinking back to sort of respiratory swabs I've done in the past, in years back in sort of babies with bronchiolitis, I'm sure I've seen things like coronavirus pop up then, and nobody's ever really paid any attention. So why is there now a big fuss about coronavirus?
So coronaviruses are really a family of viruses, and there's a few very common ones. So we think probably about 30% of cases of the common cold are due to a range of coronaviruses. But obviously, we're particularly interested in them at the moment because there's a new one. And when I say new, I mean it's never been seen before in human beings. There's a series of different coronaviruses which are known to cause severe respiratory infections in human beings, of which most people are familiar with SARS and MERS. And now, unfortunately, we've got a new coronavirus to add to the category of nasty ones. And the name of this virus is SARS-CoV-2, which is an acronym, and it stands for Severe Acute Respiratory Syndrome Coronavirus 2. And the 2 is because obviously there's another SARS coronavirus which causes SARS. So it's a little bit confusing, but probably the easiest way to refer to it is the disease that SARS-CoV-2 causes, and that's been called COVID-19. And again, that's another very handy acronym, and it stands for Coronavirus Disease 2019, which is the year that it was first discovered.
Okay, so COVID-19 is the disease, SARS-CoV-2 is actually the name of the virus.
Yeah, that's right. And it's the names are done based on sort of the genetic analysis and what we call the taxonomy. So the family of viruses it's most closely related to.
Okay, so the thing that, having encountered coronavirus before, the difference now is this is something new. This is something novel that we've not really seen globally before.
Yeah, so it's just a completely new virus. No one's entirely sure where it's come from. We're quite sure that it's what's called a zoonotic disease. So it's originated from animals. And again, virologists who have looked at the genetic makeup, it looks most similar to a type of coronavirus that's often found in bats, although it's also very similar to a coronavirus that's found in pangolins, which is one of
Yep.
my favourite animals. And I was very distraught to hear that people may end up pointing the finger at them as being an intermediate host that's brought it to human beings. But due to the way that viruses mutate and evolve, it's managed to find its way into humans.
Okay, so thinking then about, the differences, these are nasty coronaviruses, the differences between COVID-19, SARS and MERS. And I know that you and Alison Boast have written about this for Don't Forget the Bubbles. But you talk about the R0 and the case fatality rate. Can you sort of talk us through what those are and how they differ between these different diseases?
Yeah. I think the first thing to say that's really important is that these numbers are not hard and fast, and that the best way to think of them is as a rough guide. So just a general indicator of how infectious they are or how easy they are to spread. And we measure that with a figure that's called the R naught. And That particular figure means, on average, if no precautions are taken, how many infections will one case cause? So how many other people will one person infected with it give it to? And
Yeah.
that's the R naught. And then the other thing that we're obviously really interested in is how serious it is. And one of the easiest ways to measure that is how many people will die from the disease. And so that's what we call the case fatality rate. And that's as a proportion or a percentage. So of all of the people who catch the infection, what percentage of them will die from the illness? So obviously those two things are really case specific, because different countries, for example, have very different social and cultural elements that will affect how many people it is spread to. Of course, it's not a fixed number. So one person might transmit it to no one else, and one person might transmit it to 10 people. And of those 2 people, the average is 5. But of course, no one spread it to 5 people. And then again, looking at the case fatality rate, that's highly, highly context specific. So we've seen really massive differences between countries so far and how many people have died from the illness. And that's because there's such a huge number of things that can influence that. So the big one is obviously the denominator. So how many people do we know actually were infected? Because that completely changes the proportion or the percentage of deaths. Things like healthcare resources. So in very high income settings with lots of intensive care beds, hopefully you would have fewer deaths. And then obviously one of the really big things we've seen about COVID-19 is the mortality is highly age specific. So more elderly populations within countries are more likely to succumb to the illness. So it's just as a little caveat to say those 2 things are just general indicators. But if we were to compare the 3 really serious coronavirus infections, so SARS, for example, had a case fatality rate of approximately 10%.
Yeah.
And the R naught from that was about 3, so quite infectious, SARS, and again quite a high case fatality rate. MERS, which is the Middle East Respiratory Syndrome, is a very serious infection. So the case fatality rate is about 35%, so really lethal infection. But the R naught is low, so less than 1. So on average, most people will not infect anybody else. If we're looking at COVID-19, we've got to be very careful about how we interpret these numbers, because obviously it's still ongoing. There's still a lot of unknowns. But as the picture's evolved so far, estimates for the case fatality rate are anywhere between sort of 1 to 3%, or there's even been some estimates of 0.5% up to 3.5, 3.6%. And the R naught is unclear, but it's thought to be somewhere between 2 to 3. So it's quite infectious, and that's really been the main concern nationwide, globally, is how easy it's spread and how huge the numbers have been of total infections. And again, as we mentioned earlier, the other caveat to the case fatality rate is the huge discrepancy between age groups. So as of today, I've been looking very hard, and I've not been able to find any reports of fatalities under the age of 9. But the mortality rate, if you're over 80 years, is somewhere between 15 and 20%. So really, really dangerous for elderly people. But so far, it looks like not the case for the youngest patients.
Yeah. So for those comments that I've seen, sort of say, well, this is just like seasonal flu, and there's still lots of people die from seasonal flu. Then they are different. They are distinct.
Yes, they are. I mean, don't get me wrong. Seasonal flu is bad. Seasonal flu is really bad, and we probably grossly, emotionally, and sort of cognitively underestimate how bad seasonal flu is, because it just comes and goes every year. But this is certainly a lot worse, and actually the reason why it's so bad is that the caseload is not as spread out as seasonal flu. So flu tends to go over a period of quite a few months, and actually it's not as lethal, particularly for elderly people. It's not quite as dangerous, although it is a lot more dangerous for young people. But in terms of the burdens it's putting on health systems, I've seen estimates. People are saying it's around 10 times what you would expect from normal seasonal flu in terms of the burden that it puts on a health system from people being unwell.
And is another sort of factor in this the unknown, in that, for seasonal flu, this is something that we encounter. This is something that potentially we've developed some resistance to. This is something that we immunize against, whereas COVID-19 is different. It is novel. There is no vaccine as yet.
Yeah, and that's certainly been one of the main reasons why there was so much global attention on it initially, is the unknowns, and so much about it remains unknown. So we're starting to get indications of things like how it might affect unborn babies or pregnant women or children and this sort of thing. But obviously, when a brand new virus emerges, you have absolutely no idea. And if we look back to the outbreak of Zika virus and the effect that was having on newborn babies, or fetuses and microcephaly and things like that, there's always going to be a lot of concerns about these things that we don't know about. We don't know about how immunity works once you've been infected. How protected are you? And we don't know about, we still don't have full information about antigenic drift, and so how much it might change. And then, even if you've had it once, can you get it again? Is this the case with seasonal flu? So yeah, there's huge amounts of uncertainty about this virus.
Okay. So thinking then and moving on sort of clinically, what are the indications of the symptoms that we're seeing in people who've got COVID-19?
So what's really difficult about this, focusing on children, is that there's lots of unknowns about adults, but there's now, I've never seen quite so much literature come out about one disease in such a short period of time. There's even already a systematic review looking at case reports of symptom burdens and prevalence in adults. But in children, we have absolutely tiny amounts of data and information to guide us about how this presents. And actually, that's sort of good news, because the reason that we have so little information is that it seems that so few children have been unwell enough that they've made it into hospital, been tested, and then made it into case reports describing the symptoms that they've had. The sort of largest cohort papers are of between 20 and 30 children at any one time. And to be honest, those sorts of numbers, when you're looking at things like symptoms and stuff, are not that helpful, because random chance, can skew those numbers one way or another. And certainly I've looked at a few papers looking at about 20 children, and what they've described in regards to blood test results, lymphocyte counts, findings on chest CT and everything, there's actually quite big discrepancies about whether children are more likely to have lymphopenia or a lymphocytosis, whether they get ground glass changes on CT, whether they get this or they get that. So the truth is, we really don't know, because the numbers are so low in children. And I suppose the main thing to say is, it looks like from studies that have been done in contact tracing, so looking at index cases in adults and going and testing all their family members, children are, it looks like, getting infected at the same rate as adults, but they're just not displaying symptoms. There's huge numbers of children, well, not huge numbers because all these numbers are small, but there are significant numbers of children being picked up on testing who had almost no symptoms at all, or may have had a fever, or may have just normal upper respiratory tract infections like we see in children all the time. Certainly in adults, the main symptoms are fever and dry cough, or flu-like illness and myalgia. But in children, it looks like the most common thing is to have perhaps no symptoms at all, and then following on from that, normal upper respiratory tract symptoms. Or there have been some examples of children who have had some GI upset as well, so nausea, vomiting, and diarrhea. But yeah, the truth is, we're not that sure, because there's just been so few examples to look at. But it looks like it just presents, when it does present with symptoms, with those that are very, very similar to cold or flu-like symptoms.
Yeah, and I guess that in some ways that's good news, in that children seem to be relatively unaffected, and certainly on the mortality data, not affected at all from that perspective, from what we can see so far.
Yeah, absolutely. I mean, that's certainly good news for the children. It's good news for us as the people who will be looking after unwell children. But then the additional problem that poses, and this actually is not a problem that's particular to children, because I think we're seeing there's probably quite a large number of very mild cases of infection in adults. But if you're not very unwell with a virus, you don't change your behavior. You don't, feel really rubbish, so you stay in bed, or you take time off work, or you lie on the sofa, or you go to hospital and get tested and then quarantined. You just go and do all your normal stuff. And the problem is if you've got a really infectious virus and you're going and doing all your normal stuff, you're spreading it. And that's probably one of the reasons why we've seen such rapid spread across the globe, is that a lot of people haven't been that sick. And certainly children are probably quite a big part to play in that as a reservoir for the virus. So going around perhaps with no symptoms at all, and anyone who's ever seen a child will be aware that their hygiene is not paramount a lot of the time. They are quite often licking, spitting, sniffing, scratching, poking, getting their bodily secretions all over the place, really. So it's quite possible that children, as vectors for the virus, have quite a large role to play in spreading it quite widely. While that's not a big problem for them because they don't really seem to get unwell, that's obviously a really, really big problem for older or more vulnerable or frail adults with comorbidities, for whom we've seen the morbidity and mortality from the infection is huge.
Yeah, and as you say, it is that spread to the elderly, and for those people in this country, certainly, I think we're now up to 8 deaths from COVID. All of them have been having other described as having other chronic health conditions.
Yeah, and this is going to be a real. I mean, I don't envy the people working for the public health bodies at the moment, trying to make decisions about things to do with school closures and things like that. I mean, I think a lot of people have very strong opinions one way or the other, but we know, yes, that children are carrying the disease and potentially spreading it amongst each other. And so you think, well, if they're all at school, they'll be spreading it all between each other, and that's worse. But at the same time, then, if you close schools, where do those children go? They either go home and have to be looked after by their parents, who have to take time off work, who then may also get it and then be spreading it amongst their colleagues, or they're being looked after by their grandparents, who are obviously, older and potentially more frail and vulnerable. So yeah, it's a really difficult situation to manage on a sort of national policy scale.
Bringing it back to children, then, Alistair, we often sort of think about, okay, well, what are the high risk groups in the kids that we look after? So, how about neonates? Do we have any suggestion that neonates are more at risk?
So again, we're working with very limited amounts of data, so it tends to be case series of 9 or 10 women often and their babies. But there are reports of infections of children, just a few days old. So we do have reports of children having positive swabs in the neonatal period, and certainly there doesn't seem to have been any severe ill effects. They don't seem to have been any more severely affected than other infants who, as we've already discussed, don't seem to get very severe symptoms from it, which is very reassuring. Other evidence we've had is that for pregnant women who have been infected, we've not found any good evidence of vertical transmission. So, I mean, antenatal transmission. So, whilst the child is in utero, certainly we think that there's probably been transmission postnatally. And then there's been studies where they've done swabs of the placenta and amniotic fluid and everything once the baby's been delivered, and haven't managed to find any evidence of the virus there. So it's reassuring from that viewpoint, although I think quite a lot of pregnant ladies with COVID in China had their babies delivered via cesarean section early on, because there was so much uncertainty. No one was quite sure what would happen. But based on the limited evidence that we've got so far, the RCPCH, the Royal College of Paediatrics and Child Health in the UK, with the Royal College of Obstetrics and Gynecology, have come out and published some guidelines, really, really helpful guidelines that have essentially said that if a pregnant woman has COVID-19 and is in labour, that actually whatever her birth plan was should be met as long as there's no other concerns about the fetus or the mum. So they're quite happy for babies to be delivered vaginally, and also they've said there's no need to separate mum and baby once the baby's been born. So the mum doesn't need to be isolated from the baby, and equally no indication to prevent breastfeeding. There's no evidence so far of the virus being transmitted that way, and actually if you're not separating them, the mum and the baby are going to be with skin-to-skin contact regardless, so probably additional risk from breastfeeding is very, very small. And it's felt that because there's no evidence of any severe disease in newborn babies, that the harms of separating mum from baby or preventing breastfeeding would outweigh theoretical risks of the baby getting COVID-19 themselves. So no evidence as of yet that there's anything in particular to fear with neonates.
Okay, and then I guess the other high risk group of children that we look after are those who've got underlying health conditions. So thinking of children with things like congenital cardiac disease, chronic respiratory disease like cystic fibrosis, and children undergoing cancer treatment. Do we have any information about how it's potentially affecting them?
So the simple answer is no, we don't. But again, that could potentially be taken as a sort of reassuring sign. So we're not seeing many children with these conditions flooding into hospital, being desperately unwell with respiratory infections. But like I said, we just don't have any evidence to guide us. And I know this has been quite a big topic on Twitter. There's been a lot of people asking about their children, what they should be doing differently if their child has a chronic health condition. Very helpfully, in the UK, again, the Children's Cancer and Leukemia Group have posted guidance for families who have children who are having active treatment for cancer at the moment. And the guidelines are really good, really easy to read. And essentially, they say take the normal precautions you would with your child. So if there are people who would normally come and visit you who are unwell, they should stay away. If the child has a febrile illness, that should be managed in the same way it normally would, with normal protocols. And again, the advice for trying to prevent them getting COVID-19 or spreading it is the same as everyone else in terms of basic hygiene measures. So I think, so far from the evidence we've had, that there's no reason for children to be doing anything differently if they have chronic health conditions or underlying reasons why they might become more poorly, because hopefully these children who are at risk probably are doing things slightly differently anyway. They've got their own plans for what to do under those types of circumstances, and so we've got no evidence so far that they need to deviate from how they would normally manage, having unwell friends or relatives.
Okay, that's I guess that's in a way is relatively reassuring. Slightly less reassuringly, I guess, is going to be the answer to my next question, which is there any treatment so far?
No. This is the short answer. So I mean, all treatment has to be supportive in the first instance. I mean, this is true really for most viral infections we have anyway. Developing antivirals is hard. It's really, really, really hard. What is happening, fortunately, is there's a large number of clinical trials have been underway in China. I imagine we should hopefully start to see the results of those in the coming few months, but there's a whole host of stuff that's being tried. There's a new antiviral called remdesivir, which was actually recently trialed for the first time in the Ebola outbreak. Although I'm not sure what the results were of how effective that was. There's a few different trials going on of different anti-HIV medicine regimes. Chloroquine, the anti-malarial, has been shown to work in vitro in a petri dish at slowing the growth of the virus. So that's being tried. And there's even some studies where they've taken serum from adults who have survived COVID-19 infection and using that as a treatment. So, I mean, we can't speak to the possible efficacy of any of these things yet. We have to sort of await the results of the trials. And then obviously the big hope is going to be for the future, depending on what happens with COVID-19. We don't know if this is a fly-by-night, big mass infectious event that then goes away, or if it's going to turn into a seasonal virus that comes and goes. But there's certainly hopes for the development of a vaccine. And I know there's a number of groups undertaking a lot of work at the moment. I think the University of Queensland and some centres in the US are developing different types of vaccines, an RNA vaccine, amongst others, who are hoping to possibly even progress to human trials in the next couple of months. But that's obviously just early phase trials. I think there's almost no chance whatsoever that we'll have a vaccine that's ready for production this year. Part of the reason for that is there's been difficulties producing vaccines for other severe coronavirus infections. So for SARS in particular, there was a very promising vaccine candidate that went to animal testing, and in mouse models, it was found to significantly increase mortality from the infection because there was an overwhelming host response. And this is something that we have seen previously for some other viruses. One of the reasons we don't have an RSV vaccine at the moment is because there was a problem with an overactive host response following vaccination, a previous candidate vaccine for RSV that led to much more severe disease and even death. So people need to do all of the thorough testing that you would normally expect for a vaccine, even though there's a big push, there's a rush. We want it out there. We want to be protecting people. Unfortunately, there's just no corners to cut. It would be far too dangerous to skip phases and to, release and market a vaccine that could potentially make things worse. So I think that's still quite some way off.
Yeah. Okay. So without any treatment, it's about prevention, I guess, at the moment. And what are the things that we can do to minimise the risk?
So fortunately, there are definitely things we can do to minimize the risk. And a lot of these things are really quite simple. So the virus is droplet spread, and it's from respiratory secretions mainly. So you just need to think about the fact that you want to stop anything that's come from your nose or mouth going anywhere near anyone else's nose or mouth. And equally, you want to prevent anything that may have come from someone else's nose or mouth going anywhere near your own. Now, the way that it's going to get there is normally via your hands. So the first thing and the most important thing, and if no one remembers anything else I've said throughout this entire podcast, please just take away that frequent and thorough hand washing will save lives. We know that this goes back a very, very long way to our good old friend Semmelweis, who demonstrated it well. Good hand hygiene saves lives. Soap and water is fine. Soap and water is brilliant, actually. Hand sanitizer, alcohol gel is fine. It will work. It's not necessary. Soap and water will do the job. And, it's good there's loads of infographics and stuff around that you can look at about how to make sure you've covered all the easy to miss areas of your hand, and some good examples of some songs that you can sing whilst you're washing to make sure you've done it for a good period of time. And then the other thing, and I hate giving this advice because every time I hear someone say it, all I can think of is doing it, but don't touch your face. I mean, you don't realize actually how much you're touching your face until someone asks you not to touch it. And then, maybe you're just touching it because people keep telling you not to touch it. But try not to touch your face, or if you are touching your face, scratching your nose, blowing your nose, or, just scratching your eyelid or whatever, washing your hands after you've done it. And similarly, if you are having to blow your nose, things like blowing your nose into a tissue. When you've blown your nose into a tissue, don't stick it up your sleeve or on a table. Just put it in the bin. If you need to cough, it's good to cover your mouth. The best place to do that is with the crook of your elbow. So cough into your elbow. If you cough into your hands, you may not wash your hands. You may go and shake someone else's hand. So coughing into your elbow. There's been a lot of stuff about face masks. I hope most people know by now that wearing a surgical mask does nothing to protect you from other people just out in, everyday life. So if you're wearing a surgical face mask out to the supermarket, that is not helping you. If you're poorly and if you've got a cough and a runny nose and stuff, it may do something to protect other people from what you're spreading out there, but it isn't useful for protecting yourself. So that there's no need to wear surgical masks. That won't help you. So it's mainly hand hygiene, good hygiene around managing your own respiratory secretions and making sure you don't leave tissues lying around, coughing into the crook of your arm. And then the final thing is, we're getting to the stage where really, if you don't need to be getting into close personal contact with people on a day-to-day basis, like, hugging and shaking hands and all that sort of stuff, best to minimize that. And also, if you're feeling unwell, don't go and meet lots of other people. Don't say, don't sort of blow through it and say, it will be fine. I can go out to the bar, even though I've got a temperature and a runny nose and a cough and everything. It's best to self-isolate, to keep yourself away from other people. And I think that's a really important thing in this country as well. One of the messages that I think might have been lost is, even if you're worried that you have the infection, or if your child has it, if you're not seriously worried about a sort of an imminent threat to their life, in fact, even if you are, don't take them to hospital. Do not go to hospital and do not go to the GP. You need to phone 111 if you're worried, and they have a special COVID-19 hotline where they can direct you to the best way to get medical attention. Or if you're worried, for that your life is at risk, then obviously you can phone 999. But what we really don't need is people who are worried they have the infection turning up into ED waiting rooms, GP waiting rooms, and spreading it all around. So if you have those symptoms of fever and dry cough, or you're worried that your child might be at risk, keep them away from other people. Check the government and the NHS advice websites and phone the appropriate number, and you'll be directed to the right place.
Brilliant. And I think on the blog that you and Alison wrote for Don't Forget the Bubbles, there's links to the current advice on what you should do if somebody becomes unwell, and also resources for health professionals. And I guess it's important to direct people to those and say, look, this is changing very rapidly, almost on a day-to-day basis, and we all have a kind of responsibility to keep up to speed with what we're being advised.
Yeah, that's right. And actually, I've been really impressed with the national resources that have been produced both for patients and for healthcare providers. And so I would definitely advise having a read through those and keeping up to date, hopefully wherever, if you are a healthcare provider, whatever institution you're working for is keeping in close communication with you about what's happening operationally where you work. But otherwise, the national guidelines are freely and readily available, and it helps to familiarize yourself with those, because as you say, in that they're changing on an almost daily basis. And I think the expectation is that here in the UK, things are likely to change quite a lot over the next week or so.
Okay. So as I say, a caveat to this podcast is that we are recording it on the 11th of March, and everything that we've sort of talked about is correct as of to date, but things may well and almost certainly will change fairly quickly.
Yeah, that's right. So we'll just have to wait and see what happens.
Okay. Alistair, thank you so much for joining us today, and take care.
Thank you so much, Ian.